And now it's my pleasure to introduce my colleague, Dr. Nancy. Dr. Nancy will have two talks today. She is the star of the today's session, and she will talk first about cataract surgery and pediatric uveitis. Cataract surgery and uveitis is difficult. So what about cataract surgery and pediatric uveitis?
Thank you very much, Dr. Samir, for the delightful introduction. It's my honor to be here today at ASWARS, and I'm going to be discussing today first pediatric uveitis and cataracts, but especially the aspect of whether we should implant IOLs or not. So we had a study on an Egyptian population involving 766 cases. About a fourth of them were actually pediatric patients, so about 203 cases, ranging in age from 2 years to up to 18 years. And this was a 7-year study, both in Alexandria and Cairo. So what we found is that most of the cases of pediatric uveitis is chronic, especially, or the most common implicated entity is GIA uveitis, of course. 190 eyes, which is about almost half of the cases, 55.7% of the cases, or of the eyes, developed cataracts, and we saw patients that needed cataract surgery before they presented to us, during, so they can come very late with uncontrolled uveitis with cataracts on presentation, and we are in this race with time whether to operate, and we need to put them on treatment first and so on. And the intervention thus has to be very aggressive as necessary, so we can do the necessary visual rehabilitation that will help this child develop normally, and his overall behavioral development is involved. So there are multiple triggers of inflammation in cases of uveitis, and whether in pediatric or adult age, I usually tell the patient احنا هنولع نار وهنقعد نطفيها بعد ما الكاتراكت تخلص. فاحنا عندنا هنا more than one source of NOR in cases of pediatric uveitis. So the first is the primary cause of pediatric uveitis itself, and the important necessity of putting the patient on immunomodulatory therapy, very well controlled, and as Dr. Samir said, we have zero tolerance for cells in most of the cases, and a moderate tolerance for flare. So this is the first issue. The second issue is the flare-up from the surgical intervention itself, the manipulation, the things that we're going to be doing with the iris and so on. But the end, and this is the area where there's most debate, and we can debate it, me and Dr. Amgad al-Noroshi after this, the presence, or whether we implant an IOL or whether we do not implant an IOL, because this is usually the highest source of inflammation post-operative. So an IOL can further propagate inflammation, as we said, and it can cause cyclitic membrane formation, chronic hypotony, and phthisis bulbi. And this is why previously there was a direction towards lensectomy and vitrectomy approach advocated first, and then the patient goes on with an aphakic spectacle correction for life. This can be tolerable or can be accepted in patients with bilateral uveitis causing bilateral cataracts, and then we're going to remove both lenses, and then they can go for aphakic IOLs. But it's going to be a bit tricky in patients that have unilateral cataracts or bilateral asymmetric cataracts. So it's very important to put in mind all our talks collectively in this session, preoperative, intraoperative, and postoperative. But it's very important preoperatively just to go over the main points, but Dr. Samir talked about them in detail. The importance of teamwork between you and the rheumatologist, in this case the pediatric rheumatologist, in activity for at least 3 months. If the child does not have a significant cataract, the threshold for cataract surgery is quite high, so we don't operate as soon as we see a cataract. We operate if this is in any way going to develop or going to affect the child's development, whether visually or behaviorally. If not used, or if the patient was not on immunomodulatory therapy prior to his introduction to you, he must be on immunomodulatory therapy even if the cataract is significant. And we start usually with oral corticosteroids at a rate of 0.5 to 1 milligram per kg per day, and sometimes we even consider an IV corticosteroids. For the post-operative care, I'm going to be talking in detail in the next talk about post-operative care, so I'm just going to skip ahead on this one. The planning for surgery aspect in cases of pediatric uveitis, Dr. Samir has talked about it in detail, but I'm just going to highlight some points. The first point is a UBM. And a UBM is very important because it differentiates between an actual true cataract and an epilenticular membrane on top of the lens. And we actually very recently, we had a GIA patient between myself and our very eminent surgeon at Alexandria University, Dr. Nihal Shakanqiri, and he was a neglected case of GIA uveitis, and after control on treatment with adalimumab, we actually found that he had a cataract in the right eye, but an epilenticular membrane in the left eye, so she preserved his lens in the left eye. The second thing is the decision of an IOL implantation, and as we said, it would be considered a must in unilateral cases or in asymmetric bilateral cases, because as Dr. Nihal said, once aphakic, the patient will always be aphakic because of the risk of fibrosis of the capsule. Going on, if we have fibrosis that develops in the capsule, we'd be limited with the option of a sulcus IOL, which, as Dr. Amgad al-Norashi said, is not an option in cases of uveitis patients. We might also consider intravenous corticosteroid pulse at a rate of 10 milligram per kg in these patients. So here are some intraoperative tips and tricks, and we know that intraoperatively uveitis cataract is very, very tricky, and multiply this by 100 in cases of pediatric uveitis. So when we use an MVR in pediatric patients, we open only by the tip of the 20 gauge, we don't go all through, and we need to put into mind that the iris is extremely floppy, very fragile, as Dr. Samir said in the first presentation, so we don't use capsular hooks, we use iris hooks, but very, very carefully. We use iris retractors, never use capsular hooks for these because they're quite large and bulky and they can injure the iris. As regards the capsule, when we do the capsulorhexis, we aim at an anterior capsulorhexis of 5 millimeters with a posterior capsulorhexis of about 4 millimeters with a limited anterior vitrectomy. And an IOL must be completely inside the bag, preferably a single piece IOL, as a 3-piece can be quite harsh on the capsule, especially if the capsule is quite fibrotic. As to wound closure, we close all the sutures or close all the wounds with sutures, never leaving any of them leaking because of the high risk of membrane formation especially in patients post-operatively of pediatric uveitis. And at the conclusion of surgery, we go for a long-acting steroid injection, subtenon or subconjunctival. These are all our patients with long-term follow-up of 3 and 4 years. IOLs are stable, vision is preserved, and I'd like to acknowledge my very dear professor and our eminent surgeon, Dr. Nihal Shakanqiri, for I'm very blessed with her in our pediatric unit, myself on the uveitis end, and Dr. Nihal, of course, on the surgery end, and thank you very much.
Thank you very much, Dr. Nancy, for this nice presentation. So, what I understood. Thank you very much, Dr. Nancy, for this very nice presentation. So, as far as I understood, you are more towards implanting in these patients initially.
So, in bilateral cases, we go for no implantation.
No implantation.
For no
Just
implantation.
generally, yeah.
Yes, GIA cases with aggressive cataracts, VKH patients with aggressive cataracts, and so on. The question goes for unilateral cases, because it's going to be difficult for a mom to manipulate a phakic contact lens for the child, especially if he's seeing with the other eye. So this is where the thing goes. Usually you go for IOL implantation, but we try to we aim for maximum control pre-operatively, and we take all the precautions peri-operatively. And of course, Dr. Amgad, I'd like to hear your input if you do something else for unilateral cases.
Okay, so I think the situation now changed because of the progress and the advent in the materials of the IOLs and the immunosuppressives. We have the biologics now, which reduced the inflammation. So in the past, the traditional teaching, we shouldn't or we must not implant. But now I think this is a changing. I think also the cause is very important, and the worst, as we mentioned, is the GIA. And I can add to them, and we have expert here, trematode-induced uveitis. So what do you think, Dr. Amgad?
Right, Dr. Samir. I think that the cause is very important. this will be benefit for the amblyopia treatment.
Thank you very much, Dr. Amgad.